Well, I want to welcome everyone back to Prescription for Progress. It's been an incredible day-long event here, so many interesting sessions, and this is our last public session of the day. And I can't think of a better way to end the conversation than to bring in Dr. Eric Goosby, someone who I think is widely known to all of you following this, certainly a star in the global health world, former U.S. Global AIDS Coordinator during the Obama administration. He was a special envoy on TB at the UN. You've worn so many hats, Eric, across the years in global health, and currently sit at UCSF, University of California, San Francisco, as a professor of medicine, leading a center there and doing a lot of work around the world. Very engaged. You were on the Biden COVID-19 task force and engaged with the transition. So really great to get a few minutes to tap into your thinking at this crucial moment in global health. Right? We've come through. We're still in the middle of this big pandemic globally. It's changed, I think, the way many of us are thinking. So we want to tap into your thinking. This is an event about partnerships. We're trying to look at the future, what's coming, where are we? What are you thinking about? What are kind of your big picture ideas when you see the moment we're in global health today?
Thanks, Raj. It's a real pleasure to be with you today. I think this is the salient feature that is on so many countries and individual minds as we try to have the United States come back into a collegial role in the multilateral discussion, kind of in this post-COVID moment. I think our historical involvement in international work was appreciated, and I think people felt a change in the priorities as the Trump administration played out, appropriated against its priorities. And I think we are eager to pivot back into a multilateral relationship because of the threats that the planet has now are mostly going to be responded to effectively, durably through a shared responsibility pivot.
Yeah, and you're right. I mean, it's a pretty stark from Obama to Trump to Biden. This is a really big swing in the way the world's largest funder of global health sees these issues, sees multilateralism. But, speaking of the global health community, people who are trying to forge partnerships, trying to find a way through this pandemic that we're in now, what is your big takeaway about what's needed today? What do we need to do differently to get past the moment we're in and to create some better future in global health?
Well, I think we need to unpack the impact that the COVID outbreak created really at every level, both from national to provincial to local at a country level, but also the ability for a multilateral response to be orchestrated and concentrated effectively to bring needed resources, but needed capability to those settings, countries, regions that did not get a good start. And it went across both developed and developing countries in that sense. But I think we're enough past the initial responses by countries and regions in the world to understand that there are deficiencies that could be addressed more effectively or even primarily in a regional approach. To have that regional discussion, we need to have a present multilateral convener and the G7, G20 coordination, participation in that needs to be solicited and supported.
We've talked about this before, and you've been critical of the idea that, our industry, basically our global health community, is very top down still, right? It's very donor driven. It's very Northern, very Western. What do you see as that dynamic, and why is it so important we address that dynamic in the way global health is organized?
Well, I think we will not be successful in bringing the global populations toward a mean of baseline medical services that they have available to them, and just as importantly, that they receive. I think our ability to create both the capability to deliver quality medical care, to sustain that delivery, and to create systems of delivery that allow the populations, the people who need and depend on those services, to hold those allocation decision makers responsible for the decisions they made and the outcomes that they generate. That ability to understand how a program does or does not create an outcome that is desired and that the system is aware of it enough to feed it back into the subsequent planning and budget process for the next year requires a nimble surveillance, analysis, and feedback loop back into appropriator discussion for that to occur. That's something that requires a commitment by, in many instances, the donor resource, the domestic dollar resource, and then foundation and other bilateral kind of streams of input that come in. The country, if it doesn't play that coordinating role at the country level, all of these divergent resources become disarticulated, do not have an opportunity to synergize. The country begins to turn toward the donor and speak to the donor and report to the donor in somewhat of a stovepipe of activity that diminishes the ability to share and have resources coming into the country that creates systems that all can benefit from and not have to reproduce parallel systems for surveillance, for data collection, as well as for procurement distribution systems, et cetera.
So you're talking about basically strengthening health systems, right? Getting the ministries themselves to be in a position of strength, as opposed to the donor, the global multilateral institution kind of coming in and saying, this is what we ought to do and providing the resources. And it sounds like, if I'm reading kind of between the lines, you're basically saying right now the way global health works too often is the strings are pulled in Washington or in London or in Brussels, and the actual outcomes, the health outcomes, aren't prioritized. Is that sort of how you see things going?
Yes. I mean, I think they've gone that way for years. And I'm just commenting on what I think is just looking at the data in front of us. It's nothing controversial about this in my mind. I think this is how we've set it up, and there are reasons for that. Understanding those reasons has some importance, but it's really not critical to pivot into supporting systems that expand the capability of the countries that are responsible for the populations that the donor is interested in supporting. And I think we don't have too many disagreements in what we're trying to do. It's more aligning with old ways of behaving that had a role to play, looking at large programs that infused significant resources, like the President's Emergency Plan for AIDS relief, for one disease. A platform was built that is strong enough to support the response to certainly more diseases, but is a strong enough platform in terms of human resources and lab capability and procurement distribution already stood up and operating to add maternal and child health, family planning, reproductive health services to that same platform without having to create a parallel or build another clinic just for that disease or that function, which is the approach we historically gravitate toward.
Yeah, we're even seeing that with the COVID response, right? Using the PCR lab testing capabilities that were set up for HIV through PEPFAR. What do you think this means for PEPFAR, the way you're thinking? Because I could almost see what you said about needing to be outcomes focused, needing to have the countries in the driver's seat. That seems pretty well aligned in a way to what Debbie Birx, your successor it was in the Obama administration and then in the Trump administration, tried to do with PEPFAR. But there was some controversy around that idea, right, of being very heavy-handed, going to countries and saying, no, this is how you ought to spend the money. This is what the data suggests. How do you balance the desire for those outcomes and results with making sure that the countries really do have that position to decide what to do?
Well, I think it's by offering a true partnership a collegial discussion around, as a donor, this is what we are interested in funding. This is what we have talked and spoken to our appropriators about to fund. These are the outcomes that we believe we're going to create with that. But we want this to be an effort that builds on your vision of what the need is, and that can be a discussion. But we need to agree on the outcomes that we're after. And I want to understand what that donor dollar is doing in the way of the investment for which outcomes, when. And I also want to understand that for the domestic contribution that you are making to this. I want to give and work to give you complete control over management and oversight of those human resources and monetary resources, but predicated on the outcomes that we've both agreed on are achieved. And as that negotiation changes, the relative contribution of domestic versus international, with the goal for a sustainable, resilient delivery system at the end of it, I believe we can work more effectively together with that partnership arrangement than with a top-down dominated, these are what you want to do. I think my 5 years in PEPFAR did build a platform of dialogue and trust with countries around all of these issues. And I think the difference that Debbie took was more proscriptive. And I think it wasn't that the science was wrong or that she was saying something that wasn't true. She was more prescriptive. And I think that we need to look at whether or not that was effective or not and come back with a governance suggestion that I think is driven by outcome.
If you're advising the Biden administration on PEPFAR right now, you're telling them not to go in the direction that Dr. Debbie Birx took PEPFAR, but to go back maybe to the direction that you suggest, which is less prescriptive. Is that right?
Well, I mean, I've talked to them about all of these issues in just the way that we've spoken. I wouldn't have attributed it to an individual. I think there are country examples of Debbie's tenure doing exactly the right thing. I mean, it's not just there's 72 countries
Sure.
involved. There are different relationships. But I do think the trend needs to be partnership, and that we have a shared responsibility in this, that European capitals need to also acknowledge and play a role in. I think the COVID insult, if I could say it that way, has allowed us to look at the reality of what our relationships currently buy. And I think over the next 3 to 6 months, we're going to see a different distribution of the impact of COVID in sub-Saharan Africa, Southeast Asia. And now is the time for us to really galvanize the partnership.
We're getting close to the end of our time here. And I just want to ask you, you ran one of the world's biggest global health institutions in PEPFAR. It's still a fairly young institution, right? It was stood up to address a specific issue of HIV. Over the years, we've seen other big institutions, the Global Fund, Gavi, recently CEPI due to the Ebola outbreak. Now we're in a pandemic unlike anything we've ever seen. Do you want to see the world set up new institutions because of the coronavirus, some new global multilateral partnership, or do you want to see some other existing institutions strengthen? What is your view about where we ought to go from a kind of an architectural standpoint in global health?
Well, I think a pivot to opening the discussion to our colleagues in both the G7 and G20 diplomatic context is critical. That health is a major issue. COVID showed us that. It becomes a political, its solution is through a political vehicle, and we need to marry the dialogue better in getting politicians and the science involved speaking to one another. But if there is large donor commitment to doing this, I believe if we can crystallize a vision where our partner countries that we are engaged with hold the self-expectation that they will manage and oversee, monitor, and evaluate these programs, that we will work to expand their human and methodologic capabilities to do that, and continue that support, not a one point in time, but we are in a relationship that moves forward. So when new threats and new challenges present themselves, we are already in a dialogue and have means of communication that are matured enough to mount and alter a response in real time. We are not there yet. The IHR 2005 is a blueprint of sorts to go back to fill it, but we have to have the will to do it. And that requires a G7 commitment that is not present yet, but I hope the United States can play a leadership role in achieving it. Well, fascinating thoughts. And I know that our Devex Pro members and our colleagues at Devex are going to be with you in our private session in a moment, are going to have a lot of threads to pull on there. This is a transformational moment. Something is going to come out of it. And you are one of the people helping to shape that. And so we really appreciate getting your time here today and being a part of Prescription for Progress. Thank you for being here. Pleasure.